Welcome back to this next video in which we are discussing inflammatory bowel disease. Okay, so we're currently in the process of discussing the pathophysiology of inflammatory bowel disease. And in this next video, what I want to do is explain to you where the symptoms of inflammatory bowel disease flare-ups are actually going to come from. And I want to explain why, or give you a possible explanation as to why inflammatory bowel disease is an episodic disease. Why does it follow a relapsing, remitting course? Why does the inflammation come and go? Okay, but first, allow me to summarise where we've got to in the pathophysiology so far to make sure that we all completely understand it. So remember, inflammatory bowel disease is not believed to be an autoimmune disease. Instead, it's believed to be a failure of immune tolerance to the commensals within the intestine. And Crohn's disease and ulcerative colitis are believed to be attacks on different commensals within the intestine that are in different locations within the gut, and hence why the inflammation in these two different forms of inflammatory bowel disease occurs in different distributions. So, in an individual who's going to develop inflammatory bowel disease, you end up with naive CD4 positive T cells that are directed against peptide fragments of the proteins of that commensal that you're going to attack. And what follows is that when the commensal is present within the intestine in a high prevalence, and remember the possible explanation for why you can have the CD4 positive T cell clone long before you actually develop inflammatory bowel disease is that potentially the commensal is not actually present in high enough levels, and it only comes about that you get the inflammatory bowel disease once the microbiota has evolved and now that commensal is present in a much higher proportion. When that commensal is present in a high proportion, you're going to get sampling of that commensal by the M cells, which will then hand it to the sentinel cells in the lamina propria, the resident macrophages in the dendritic cells. Because it's a commensal, they will not initiate the inflammatory response. However, they double check it by taking it to lymphoid aggregates within the lamina propria. So they will chop up the proteins of that commensal and present it to naive CD4 positive T cells within the gut lymphoid aggregates. And now, if we've got those CD4 positive T cell clones that are directed against a peptide fragment of that commensal, then they will actually be activated. They will divide and divide and divide and differentiate into memory cells and effector cells. Now, here is where Crohn's disease and ulcerative colitis differ in which type of helper T cells that you actually get produced. So in Crohn's disease, you get T helper 1 cells as the main type of effector helper T cell, whereas in ulcerative colitis, you get T helper 2 cells as your main type of effector helper T cell. And we've discussed that the way that you cause effector helper T cells to become T helper 1 cells is by secreting interleukin 12, and to get the effector T helper cells to become T helper 2 cells, you need to secrete interleukin 4, and this job is done by the antigen presenting cells. So for some reason, when the antigen presenting cells present the peptide fragments of the commensal that is being attacked in Crohn's disease, they release interleukin 12, and in ulcerative colitis, for some reason, they release interleukin 4. Again, I can't really offer you a brilliant explanation as to why that is, but that must be what happens in order to get these forms of effector T helper cells being produced. Now, in Crohn's disease, then, the T helper 1 cells will then go up to the lamina propria. They'll interact with the antigen-presenting cells that have the peptide fragment that they are directed against on their surface bound to MHC class 2. They'll then know they're in the correct position. And what does this cause? They cause the antigen-presenting cells, the resident macrophages and dendritic cells, to release the pro-inflammatory mediators, the two major ones being interleukin-1 and human necrosis factor alpha, which will then cause the inflammatory response in the microvasculature, which will produce you an exudate and which will bring you in neutrophils and macrophages. In addition, the T helper 1 cells, with all of the macrophages that are coming in, will form these granulomatous arrangements where you have the macrophages inside and then the T helper 1 cells around the outside. And remember, that's because T helper 1 cells are giving instructions to the macrophages. They're giving this interferon gamma, which is helping the macrophages to destroy microorganisms when they're phagocytosing them. So, in Crohn's disease, you're going to get inflammation occurring within the lamina propria, exudate, neutrophils, macrophages, and the macrophages with the T helper 1 cells are going to form granulomas. Coming on to ulcerative colitis, the T helper 2 cells will go up to where the antigen-presenting cells are. Again, they will interact with antigen-presenting cells that have the peptide fragment that they're directed against bound to MHC class II molecules on their surface, and again, they will activate the antigen-presenting cells to release the 2 major pro-inflammatory mediators and a whole bunch of other pro-inflammatory mediators that I'm going to introduce you to in a moment because it's important when we're trying to justify some of the other symptoms. But, of course, interleukin-1 and TNF-alpha are the major ones. They actually are the big drivers of inflammation. They will cause an exudate to be formed, and neutrophils and macrophages will come out. In addition, the T helper 2 cells will also release interleukin-5 and interleukin-13 that will call for eosinophils, so you also bring in eosinophils. So in ulcerative colitis, you get an exudate being formed in the lamina propria, and you're going to get neutrophils, macrophages, and eosinophils coming in, but you're not going to get granuloma formation. So there we go. We now understand how the adaptive immune response can then trigger the innate immune response to come into the lamina propria. So the adaptive immune response goes first, then the innate immune response, which is the exact opposite of the way it usually occurs when you're dealing with a pathogen. If you were actually dealing with a pathogen, the innate immune response would have occurred first. Now, let me point out that the reason this disease can go on and on and on is because you can continue producing more and more of the effector helper T cells. So these T helper 1 cells and the T helper 2 cells that have come in inflammatory bowel disease, they won't live forever. They live for a few weeks maximum. So for the disease to go on and on and on, you have to continually reactivate the adaptive immune response, and you can do that because you have created the memory CD4 positive T cells, which when they're activated by antigen-presenting cells presenting the peptide fragment, do exactly the same thing as the naive CD4 positive T cell did, i.e. they divide, and then their progeny will differentiate, some into effector helper T cells, and some then into more memory CD4 positive T cells. So it goes round and round and round, which is why you continue to launch the adaptive immune response against the commensal as long as the commensal is present. Now, that's what we've discussed so far. Let me now justify to you why you get all of the different symptoms that we initially listed off as the symptoms of an inflammatory bowel disease flare-up. So remember, we said that the symptoms of an inflammatory bowel disease flare-up were abdominal pain, diarrhea, which might contain blood and mucus, the constitutional symptoms of inflammation, so things like a raised body temperature, fatigue, malaise, muscle aches, tension-type headaches, and also weight loss. So we now want to justify where those are going to come from. Now, to justify these symptoms of an inflammatory bowel disease flare-up, we actually need to talk about some more inflammatory mediators. So I simplified it down initially. When you get inflammation, I told you that interleukin-1 and TNF-alpha are released, and these are the major drivers of inflammation, and that's not a lie. They are. If you're just going to learn 2 inflammatory mediators, they are the major ones to learn. They actually go to the microvasculature blood vessels and make them produce an exudate and recruit white blood cells. Very, very powerful molecules as far as inflammation is concerned. However, these resident macrophages and dendritic cells, the sentinel cells, when they want to initiate inflammation, either because they've seen the pathogen themselves or because the helper T cells are commanding them to cause inflammation, as is the case in inflammatory bowel disease. They release more than just interleukin-1 and TNF-alpha, and it's now time for me to introduce you to some of the others, because we're going to need them to justify some of these symptoms. So a very important one is something called prostaglandin E2, PGE2 for short. So let me write its full name down over here. So this is prostaglandin, that's the PG, and then it's prostaglandin E2. Then another very important one is interleukin 6, so IL-6 for short. And then the final one that we're going to need to talk about, there are of course loads more, but to justify the symptoms, these are the ones we need, is something called platelet activating factor, or PAF for short. So that stands for platelet, that's the P, and then the A is for activating, and then the F is for factor. So platelet activating factor. So these are more inflammatory mediators. They have different roles to interleukin-1 and TNF-alpha. As I say, interleukin-1 and TNF-alpha, they are the major pro-inflammatory mediators. They cause inflammation. They act on the cells of the microvasculature to trigger the production of the exudate and the recruitment of the white blood cells. So they are the major pro-inflammatory mediators. These are other mediators released at areas where there is inflammation occurring, but their roles are slightly different. They don't cause quite the same effect as interleukin-1 and TNF-alpha. They don't trigger inflammation. They trigger other components of the inflammation. So let's start off with prostaglandin E2. Prostaglandin E2 is the major mediator of inflammatory pain. So you're probably very much so aware of this. Wherever you get inflammation occurring in a portion of tissue within the body, that portion of tissue becomes painful. And that sort of pain that you get in an area where inflammation is occurring is what we call inflammatory pain. And it's believed to be caused by this mediator, prostaglandin E2. So at sites of inflammation, the sentinel cells will be releasing prostaglandin E2, and this is going to activate pain neurons and trigger pain. And because that pain's been triggered by inflammation, we call it inflammatory pain. Okay, so prostaglandin E2 is being released in the lamina propria, and this is now going to activate pain neurons within the wall of the intestine. And of course, if we're dealing with the small intestine, it will be pain neurons in the small intestine. If we're dealing with the large intestine, it will be pain neurons in the large intestine. So let me just add this onto my picture of the intestine here. So in the lamina propria, another structure to add in, not just is there all the blood vessels and the lymphatic vessels and the connective tissue and the fibroblasts, but you're also going to have nociceptors, which are the sensory structures on the end of pain neurons, which look like trees, like so. So here on the end of this pain neuron, like so, that tree-like structure that I've just drawn in there, that's what we call a nociceptor. Now, a nociceptor is this tree-like structure on the end of the axon. Here's the axon of the neuron. And it will have loads of receptors in its surface that are all trying to detect noxious stimuli. And if they find noxious stimuli, they will be activated, and they will try to make the axon fire an action potential. And when the axon fires an action potential, that's what will give you the sensation of pain. So nociceptors have receptors in the membrane, and that's why we've got this tree-like structure. It's to increase the surface area of the membrane here, and these receptors are detecting noxious stimuli, which are stimuli that should cause pain. So this is a fancy piece of terminology. Noxious stimuli means stimuli that should cause pain. So, prostaglandin E2 is a noxious stimulus. It can activate receptors in nociceptors and cause those nociceptors to fire action potentials, and that will give rise to pain. And this is exactly what's going to happen in the intestine. So prostaglandin E2 being produced by the sentinel cells as part of the inflammatory response is going to activate nociceptors within the lamina propria, and this is going to cause the axons that those nociceptors are attached to, the pain neurons that those nociceptors are attached to fire action potentials, and that will give rise to the symptom of abdominal pain. Okay, where are we? So it is prostaglandin E2 then that is believed to mediate the inflammatory pain, the abdominal pain that you're going to get as part of an inflammatory bowel disease flare-up. So when the inflammation is present, it's prostaglandin E2 that's causing that abdominal pain. Next, let's talk about diarrhea, so too much fluid in your poo. So there are 3 reasons that you get diarrhea, and where should I put these? I think I'll put them down here. So 3 reasons that you get diarrhea, so I'll just put a little title here. So the diarrhea is not simple, it's got 3 different reasons that give rise to the diarrhea. So the first one is, of course, that we are producing an inflammatory exudate. So as part of the inflammation, we are bringing in lots of fluid from the microvasculature blood vessels that contains proteins from the bloodstream that are going to attack the pathogen. And this exudate doesn't just stay in the lamina propria, it will go through the lamina propria, through the epithelium, and into the lumen, and therefore it's going to make the contents more liquidy. So that's one reason that you're going to get diarrhea. Reason number 2 is that when you have got inflammation occurring in a portion of the wall of the intestine, absorption is going to be reduced. So absorption is going to be jeopardized, and then if absorption isn't going so well, of course that might mean that fluid isn't going to be absorbed properly and instead is going to remain within the lumen, and again that can increase the amount of fluid in your poo, so that can also lead to diarrhea. So because absorption is damaged by the inflammatory process occurring in a portion of the intestine, that can then lead to too much fluid remaining within the lumen and therefore diarrhea. And the third reason that you get diarrhea, number 3 here, is that secretion of fluid is going to go up. So what's going to cause secretion of fluid to go up? So you remember when I was telling you about the epithelium of the intestine, I told you that the enterocytes in the small intestine and the colonic epithelial cells in the large intestine, these produce a serous secretion, a watery secretion full of electrolytes. And then the goblet cells add mucins to this to make it more viscous and turn it into a more mucus secretion, and that produces us the mucus here. Well, what's going to happen when you've got inflammation occurring within the lamina propria, within the wall of the bowel? You actually get the enterocytes of the small intestine, or the colonic epithelial cells if we're talking about the large intestine, producing more serous secretion. So their rate of serous secretion goes up, and therefore more fluid is going to go into the lumen of the intestine. And again, this is to try and wash away whatever it is that is causing the inflammation. Remember, we think that there is something very dangerous, a pathogen has triggered this inflammation. We'd quite like to flush this pathogen out, and washing it away would be quite helpful. So that's the sort of motivation behind why we want to increase the serous secretion of the epithelial cells. The actual mechanism is platelet activating factor. So platelet activating factor, this molecule is going to go up to the enterocytes if we're talking about the small intestine, or the colonic epithelial cells if we're talking about the large intestine, and it's going to act on receptors on their surface and increase the rate at which they are secreting serous fluid, and that's also going to result in the diarrhea. So 3 reasons that you get the diarrhea: the exudate, the lack of absorption, and the actual increased secretion of serous fluid due to platelet activating factor. And that's the reason I wanted to tell you about platelet activating factor as one of the inflammatory mediators, because it's important in explaining diarrhea. Now, of course, the diarrhea can end up being mucousy and also bloody. So let's explain this. What's the mucus? The mucus is going to be a mixture of exudate and also white blood cells. So pus is what I mean by mucus in the diarrhea. And pus is loads and loads of white blood cells. So the white blood cells that you're bringing in as part of the inflammatory response, the neutrophils and the macrophages, a lot of these won't just stay in the lamina propria, they'll go through into the lumen, and they'll therefore end up in the poo, and therefore you can end up with mucus or pus within the diarrhea. So it's probably best to call it pus, because everyone knows that pus is white blood cells effectively. So you can end up with pus in the diarrhea, and you can also end up with blood in the diarrhea. Now, how does this occur? Well, this is particularly something that happens in ulcerative colitis, more so than in Crohn's disease. You see, when you have this inflammation occurring within the wall of the bowel, you get damage to the wall of the bowel, and this can end up breaking open blood vessels, and therefore you bleeding into the lumen of the intestine, which is how you can end up with blood in the diarrhea. Now, why does it occur more in ulcerative colitis? Well, we know in ulcerative colitis, you don't just bring in neutrophils and macrophages, you bring in these horrible, horrible cells, two powerful cells, eosinophils, which will cause major tissue damage. And it's this that leads to ulcerative colitis being more damaging to the wall of the intestine generally than Crohn's disease. And indeed, this is the reason ulcerative colitis is called ulcerative colitis, because you end up with ulcers forming in the large intestine. An ulcer is where you've got a hole in the wall of something. So when you've got an ulcer in the stomach, that is a hole in the wall that doesn't necessarily go all the way through the wall, but a great big gash out of the wall. So going up to my picture, if you imagine taking a great big lump out here, imagine cutting this all the way and taking that bit completely out, that would be then an ulcer, an open wound in the wall of the intestine. And because of the huge damage that the inflammation can cause in ulcerative colitis, you do indeed end up with these ulcers in the large intestine and the rectum, and you can bleed from those ulcers. And as I say, the reason ulcerative colitis is so much more destructive to the wall than Crohn's disease is the eosinophils. Crohn's disease can also result in massive tissue destruction, and therefore you can also end up bleeding into the lumen as well in Crohn's disease, but it's more rare that Crohn's disease causes that. Okay, so that's diarrhea accounted for. Next, we want to account for the constitutional symptoms of inflammation. So the high temperature, the fever, the psychological symptoms, the tiredness called fatigue, the malaise, the feeling unwell, and then the muscle aches, and also the tension type headache. How can we account for these? So, these, as I say, are symptoms that you get whenever you've got inflammation occurring anywhere in the body. So, why do you actually get them? Well, it's because when you've got inflammation occurring in a portion of tissue within the body, the inflammatory mediators that are being released in that tissue do not just stay in that tissue. Some of them go into the blood, and the ones that are particularly powerful at going into the blood are interleukin-1, TNF-alpha, and interleukin-6. So let's just go over to the side here and discuss the constitutional symptoms. So these mediators, interleukin-1 and tumor necrosis factor alpha, forever shall their names be revered, very, very important. And then also this other one, interleukin-6, which is very important whenever you're talking about constitutional symptoms of inflammation. So these three very important mediators, these are going to leave the tissue where they've been secreted. Some of them, of course, will stay there, and they'll, if they're interleukin-1 and TNF-alpha, they are going to be the major drivers of inflammation. But they're also going to go into the bloodstream, and they're going to cause systemic effects. So they are going to go up to the brain, and by going up to the brain, they will change the set body temperature. So they're going to raise body temperature. So I'll just put T there for temperature. So they raise the set point that you want the body temperature to be, and therefore the body takes actions to conserve heat and generate more heat to raise your body temperature up to that new set point. They will also make you feel tired, so you'll get fatigue because of these mediators going up to the brain, and they'll also make you feel unwell. So it's these mediators in your bloodstream that make you feel unwell and tired when you've got inflammation occurring somewhere within your body. So remember the last time you had flu, you had inflammation occurring within your respiratory tract. The reason you felt so tired and the reason you felt so unwell is that these mediators, interleukin-1, TNF-alpha, and interleukin-6, were being produced at that site of inflammation, going into the blood and going up to your brain and triggering that effect. Now, let's try and justify why they trigger the muscle aches. And actually, the reason that they trigger the muscle aches and the reason that they trigger the tension type headache is believed to actually be extremely related. So I'll just put TTH here for tension type headache. So, how do they trigger those muscle aches? And remember, the muscle aches, again, think back to when you've had flu and your limbs have been aching and maybe your back's been aching as well. That's what I mean by muscle aches. So how does this occur? These mediators go to the skeletal muscle in your limbs and in your back, and they're actually are believed to end up producing prostaglandin E2. So when they go to these distal muscle tissues, they end up producing the mediator of inflammatory pain there. So they end up producing prostaglandin E2, and this will then activate the nociceptors within that muscle tissue to trigger the muscle aches. So that's believed to be where the muscle aches come from as a systemic sign of inflammation. With regards to tension type headaches, this is where it's very, very nice. We believe the mechanism is the same, just in this case, it's going up to the muscles in the head region. So it's going up to the muscles in the frontal region, the forehead region of your head. It's going up to the temporalis muscle in the temporal region of your head, which is the side of your head. And it goes to the occipitalis muscle in the back region of your head. So by going up to those muscles in the portion of your head that actually surrounds your brain, it will again trigger the production of prostaglandin E2 there, and then trigger pain coming from those muscles. So tension type headaches, that squeezing headache, that bilateral headache that feels as though it's squeezing, we've all had them before. They're the same type of headache that you get when you've had a very stressful day at work and you then get a headache. But it's also the type of headache that you get when you've got flu and you've got inflammation occurring in your respiratory tract. And indeed, it's the type of headache that you get whenever you've got inflammation occurring anywhere. It's believed to originate extracranially, so it isn't believed to originate intracranially, unlike migraine headaches, which are believed to originate intracranially by activation of the meningeal nociceptors. But in the case of tension-type headaches, we believe it originates extracranially and that the pain is coming from the muscles in the portion of the head that surrounds the brain, and that's why you get that bilateral squeezing headache. So muscle aches and tension-type headaches are believed to be effectively the same mechanism. These mediators go to those muscle tissues, trigger the production of prostaglandin E2, which activates nociceptors that are innervating those muscle tissues and therefore triggers pain. So these then, I'll remind you, they have this big grandiose name. These are referred to as the constitutional or the global or the systemic symptoms of inflammation, and you get these whenever you've got inflammation occurring anywhere in the body. And the more inflammation you've got, the more mediators will be going into the blood, the worse these symptoms will be. Okay, so those are the constitutional symptoms. Finally, weight loss is very easy to justify. If you've got this inflammation occurring within part of your intestine, you might not be absorbing nutrients properly, and therefore you're going to end up losing weight. So that justifies the symptoms of a flare-up of inflammatory bowel disease. The final thing that I want to discuss before we finish our discussion of the pathophysiology and go on to drugs is to try and give you an explanation as to why this disease might follow a relapsing, remitting course. So remember, it comes in episodes. The inflammation is not going to be present all the time. You get episodes where you have inflammation occurring within the intestine, and then it goes away, you have a portion of remission, and then it relapses and it comes back. So it comes and goes. Now, why is that? Well, the speculation, and again, this is just speculation, it's a theory that might be the reason, is that potentially the inflammatory response you initiate succeeds in annihilating the commensal that it's attacking. I.e., the adaptive immune response has attacked this commensal. Maybe we actually succeed in annihilating it, and then once it's annihilated, everything will settle down, the effector helper T cells will all gradually die, you won't get the reactivation of the adaptive immune response because there's no commensals currently present within the intestine. We've annihilated the one that we're against. And once these are gone, then of course you will no longer get the antigen-presenting cells releasing the pro-inflammatory mediators, and therefore the inflammation will stop. So the idea is that you will go into remission once you have succeeded in annihilating the commensal that the adaptive immune response is so set on destroying. Then, why will it relapse? Well, maybe the commensal comes back. Once the immune response has stopped attacking it, maybe it then comes back, and then you get another adaptive immune response initiated, and then the whole thing happens again. So it goes round and round in a cycle in a relapsing, remitting course. Okay, so there we are. That's the story of the pathophysiology of inflammatory bowel disease, the two major forms of inflammatory bowel disease as we currently understand it. I'll stress again that we believe that in the two different forms of inflammatory bowel disease, Crohn's disease and ulcerative colitis, we believe that the adaptive immune response is attacking a different commensal, and hence the different distributions of the inflammation and the different types of inflammation that are going to occur, the different types of adaptive immune response that occur, the T helper 1 versus the T helper 2 of ulcerative colitis. Okay, so we'll have a break here, and in the next video we'll turn our attention onto the drug treatment of inflammatory bowel disease.